this morning. I want to thank the organizers for this wonderful meeting and for giving me the opportunity to present today. This is going to be, after all this MRI, going to be a chest X-ray based talk. And again, I would like to, my disclosures, I don't have anything to disclose. And the purpose of my talk is that you should be able to recognize the device on a chest X-ray. You should know its indication and function, how it was placed, how it got there, and the usual, or I would say, typical location. And the devices that I will be discussing are ventricular assist devices, both for the left and right ventricle, both temporary and permanent devices. I will briefly touch on surgical valves and talk more about percutaneous or minimally invasively placed valves. And then lastly, I will discuss exclusion devices. So jumping right in, this is probably the most familiar left ventricular assist device that we've all seen on chest X-rays on our daily readouts. This is the heart-mate left ventricular assist device with the left ventricular outflow cannula placed via a stab incision into the left ventricular apex and sutured in with a purse string. This left ventricular outflow cannula should point slightly towards the mitral valve and should not tend the left ventricular myocardium. The valve is driven, or excuse me, the LVAD is driven by a rotary blood pump, so the patient will not have a measurable pulse, and it is supplied by a drive line that usually exits the patient's abdominal cavity in the right upper quadrant. And lastly, to close the LVAD circuit, there's the radiolucent pump aortograft, which you can sometimes appreciate on a lateral radiograph, right retrosternally. It attaches to the distal ascending aorta and closes the circuit. The patient has also, as you can see, a biventricular AICD and pacemaker, which I was not discussing. Another left ventricular assist device that you've probably seen is the hardware, which has a much smaller footprint. It has the same purpose and it has the same functionality, it's just a much smaller device. You see the left ventricular outflow cannula, again placed within the left ventricle with a stab incision pointing at the mitral valve. The rotary pump is directly connected to the left ventricular cannula and provides, again, a non-pulsatile flow. There is a drive line which supplies this device with power, and the radiolucent pump aorta graft connection has a connecting piece, which is a constraining release device that is between the ring that is depicted at the yellow area and the rotary butt pump. And the anastomosis is again to the distal ascending aorta. Now moving on to the more temporary devices, we have seen this on a prior excellent talk. This is the Impella device, and to mag it up a little bit, so to me it resembles more a cocktail stirrer than a hockey stick, but that's personal preference. And the important thing about these devices is they're placed intraarterially via usually a femoral artery stick, and the placement should be below and above the aortic valve. So the two radio-opaque markers that you're seeing here, which is this one and this one, should be placed below and above the expected location of the aortic valve. On a schematic, it delivers forward flow from the left ventricle into the aorta and therefore reduces myocardial workload and O2 consumption, but only if positioned properly. I'm moving on to the so-called tandem heart, and the tandem heart pretty much just describes the pump that drives the device. And depending on where the cannulas are positioned on the patient, it will act as a left ventricular assist device or as a right ventricular assist device. In this patient, it's a left ventricular assist device placed percutaneously with a cannula that is inserted intravenous through the right atrium and then with a transseptal approach positioned in the left atrium. And the circuit is closed with a right femoral arterial cannula that I'm not depicting here in this slide. This is a schematic that I borrowed from the manufacturers and from a paper in circulation. This is the actual pump that drives the system. And it is a bridging therapy that can be used from a few hours to up to 14 days in patient post-cardiogenic shock. The surgical placement is also an option. This is a patient post-mitral valve replacement who still has an open sternotomy, and there is a left atrial cannula with via a left pulmonary vein, depicted here on the right side of the patient. Excuse me, it should be right. And then additionally, there is a ascending aorta cannula which extends to the expected location of the distal ascending aorta. And therefore, the left ventricular assist device circuit is again closed. This is a new device, it's called the Protect Duo, and it's a single cannula for both blood aspiration and blood expulsion in patients with right ventricular failure. It is placed via a right internal jugular vein, and the tip is positioned in the right ventricle with the inflow, and the outflow is positioned within the right atrium. It is, as I mentioned, a single cannula, and you can, the patient can be supplied with an oxygenation device that can be interconnected between the tandem heart and the cannula. I will not touch much on the surgical valves because we're all very familiar with the different devices, and it has been nicely described by one of our prior speakers. There's the mechanical valve, the cage ball, we're all familiar, the bileaflet valve, and I will focus more on the bioprosthetic valves. The advantage of the bioprosthetic valves is that the patient will not require anticoagulation. The disadvantage, however, is that they have a much shorter lifetime. And if you see a patient like we see and they're in the ICU and not doing well and the valves are not properly positioned, you still wonder what kind of a valve it is. And the nice thing about this particular valve is that it will show you the direction of the flow, because to me, and I have 2 daughters, and those of you who have 2 daughters probably understand what I'm talking about, this looks like a tiara. And so the points of the tiara point in the direction of the flow. So depending on where you have the points of that valve scaffolding directed, you can say this is an aortic valve or a mitral valve and vice versa. This is a different bioprosthetic tissue valve, and all it has as a footprint are 3 radio-opaque rings which are placed at the tip of the cusps. This is the Medtronic mosaic valve, and it can be used in younger patients, both in the AVR and MVR position. It does not require anticoagulation, which brings me to the more modern valves, or the valves that we've been now seeing more rapidly increasing in numbers, which are the transcatheter valves. They come as a pulmonary valve, which we're probably more familiar with, and balloon expandable and self-expandable aortic valve. I will then touch also on mitral valve repair mechanisms, a so-called mitral clip. This is a young patient with a history of tetralogy of Fallot, depicting this stent scaffolding in the expected location of the right ventricular outflow tract. And this is a so-called melody valve. It is a metal stent, a balloon expandable stent with porcine pericardium mounted onto it, and it is balloon expandable. It usually is used as a bridging therapy to more permanent solution with a mechanical valve, and one has to keep in mind that those patients have undergone multiple cardiac surgeries, multiple sternotomies, and this aids as a bridge so that they don't have to go an additional sternotomy. The majority of those patients have a history of tetralogy of Fallot. These are the valves that have been discussed here extensively, which is the Edwards-Sapien transcatheter aortic valve. They are bioprosthetic valves mounted on a balloon expandable stent, and they are used in the treatment of aortic stenosis. There are multiple approaches how these valves can be placed. The most common one is the transfemoral approach, but they can be placed transapically, transaortic, or transsubclavian. And it is important to know how they were placed, because that also will tell you what possible complications this patient will have after placement of the valve. These patients are usually patients with high surgical risk or are inoperable, at least at the current time, under FDA approval. And this is a placement video. You notice the rib spreader, so this is a patient who received his valve with the transapical approach. There is a transesophageal echo probe in the back, and the balloon is inflated, and the valve is placed in position and will remain there. The thing is that with transapical approach, the patient is at much higher risk of developing post-procedural hemopericardium and hemothorax, so you need to watch out for this. If you see a patient post-transcatheter valve with the left-sided chest tube, you know that there has been a transapical approach. The other transcatheter aortic valve is the Medtronic core valve, which has a completely different footprint because it is a self-expandable nitinol stent in which porcine pericardium is embedded into, and it is exclusively placed via a transfemoral approach. The centering or the positioning of the valve is centered within the sinus of Valsalva, so it covers a much bigger footprint and it covers a much bigger area than the Edwards sapien, which is anchored right in the aortic annulus. And then moving on to the mitral clip, these are very small devices that look like old-fashioned clothespins, and that's exactly what they do. So they act as clips that grasp both the anterior and the posterior leaflet of the mitral valve, closing together, and by doing so, creating smaller lumina or smaller orifices, opening orifices of the mitral valve. They are also placed via a transseptal approach. So the catheter comes in through the right atrium. There's a transseptal puncture, and the valve is then grasped, and the clip is closed. This is how the clip looks magnified, and they're designed to reduce mitral regurgitation. And like I said, it's a transcutaneous transseptal approach. And the last device that I want to touch is the left atrial appendage clip. These are used in patients with persistent atrial fibrillation or long-standing atrial fibrillation, and they're not placed exclusively. So they're usually placed in patients who undergo concomitant CABG or valve replacement or repair. They come in different sizes, and their goal is to exclude the left atrial appendage and therefore reduce the risk of thromboembolic events. They look like, to my eyes, like the potato chip bag clips that you can buy at the grocery store, and that's exactly their function. You close the bag, and then nothing can come in and nothing can go out anymore. On a radiograph, they have this very characteristic footprint of two parallel metal bars with these small connecting hooks on the side, and this patient underwent CABG and so simultaneously had an exclusion of his left atrial appendage. And this is the clip. And then when we put it all together, and I don't know about you, but we sometimes get very little information about our patients, and you get a chest x-ray, and then you have to figure out what's wrong with that patient, what happened to that patient. Now you can see that this patient has a story to tell, so he underwent both an aortic valve repair. The prongs of the tips of the valve point in the direction of the aortic outflow. He had a repair of a leaky mitral valve, and then he had a concomitant exclusion of his left atrial appendage with a left atrial appendage clip in place. And with that, I thank you for your attention.